What to expect with IVF step by step. Hi, friends. I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI. So I'm a fertility doctor, and I talk about IVF every single day. Yet, so often people go into this process without knowing what to expect. This video is going to break down for you what you should know about IVF, how to think about the process, so that you can be prepared either to go through the process yourself or to help support a friend or family member who might be going through IVF. Before we dive in, a huge thanks for being here. As always, I am so thankful for you. So please consider subscribing, liking, sharing, and commenting because our video ideas come from your questions right in the comments or in the community tab. Also, I want to say huge thanks for all your support on my book, The Fertility Formula. You can buy The Fertility Formula anywhere books are sold and in your favorite format. And it's really a resource to help you understand your body better, no matter if you're trying to get pregnant or even navigating IVF. Because even when we do IVF, there's sometimes this idea that IVF will just take care of it and you no longer have to worry about lifestyle or other factors. But the reality is that IVF is very nuanced and there's so much you need to know that even with IVF, I can only work with the eggs and sperm that I am given. So even though we are going to walk through what to expect from a procedural standpoint, it's really important to know that when you go into IVF, taking care of your lifestyle, decreasing inflammation, working to improve insulin resistance for both partners is really important. The life cycle of sperm is about 90 days. Eggs are inside your body your entire life, but we know that in the 60 to 90 days prior to ovulation or getting to maturity, they are most sensitive to the world around them. So if you are going through IVF, that doesn't mean you need to wait to make good lifestyle choices because IVF takes a long time. But you can start making much improved choices right this moment, and that will positively impact your egg quality and your sperm quality. When we think about IVF, one fear that I hear all the time is people will say, well, I don't want to do IVF because I don't want to run out of eggs faster. And I get this fear, but it's actually not based in any science. So let's think about what IVF is. I want you to first roll back to my favorite vault analogy. Imagine that this is your ovary, and inside your ovary is a vault where all your eggs are kept. You are born with all the eggs you're ever going to have, and every month a group of eggs comes out of this vault where they are all stored. Now, in a normal month when you're not doing IVF, every single egg grows inside a follicle, and we can even do an ultrasound and get a count of these follicles called an AFC or an antral follicle count. Well, naturally, the brain will send out a hormone called FSH, follicle stimulating hormone, and FSH works to get one follicle to grow. As that follicle grows, it is going to get bigger. The egg inside is going to mature and make estrogen. And this will be the one that you ovulate while the rest of the eggs die. And then the next month, you have another group of eggs coming out. So to answer the question, when we think about IVF, I can only get the eggs outside the vault to grow. I do not have the science, at least right now, to tap into the vault. So this means that one, we are limited by how many eggs you're sending out of the vault. Two, I have to get them to mature inside your body first, which is part of what we are trying to accomplish. But three, you are not going to run out of eggs any faster. The eggs that came out of the vault were going to die if we didn't use them for IVF. So we're simply trying to get more eggs to have an opportunity this month than nature would allow. So step number one before IVF should be proper evaluation. This would include testing your ovarian reserve, which is how many eggs are outside the vault, done with both the AFC, antral follicle count on ultrasound, and two, AMH, blood test. Anti-Mullerian hormone, or AMH, is made from the cells that surround all of the eggs outside the vault. So more eggs in the vault, more come out every month. These two tests should help us then determine the protocol or the combination of medications you're going to use. We also want to get a semen analysis. Nobody should be proceeding with IVF without a semen analysis because we need sperm. You need to know what type of fertilization you're going to have, and you need to know if there's enough sperm for the process to be successful. Different things can impact sperm quality and quantity, so initial testing is essential. So that would be step number one. Step number two is going to be you're going to get a protocol. And I think it's very important that you know it is a red flag if your doctor sits here and says, this is the protocol we always do. Your protocol should be personalized based on your scenario. So that antral follicle count and AMH, but then also, do you have endometriosis or PMOS? Do you have autoimmune disease? What else is going on in your history that can play a role in what medications we may need to get to have you respond and to get the best outcome? Now, how do we think about the protocol? I like to think about it as suppression and stimulation. So when choosing the protocol, here's the bad analogy I use. Let's imagine that every month you have that group of eggs coming out of the vault, and let's imagine a nest of baby birds. So normally, mommy bird is bringing in the one worm, the biggest bird gets the worm, and that's the one that grows to get big. So if we think about that with your eggs, the brain is sending out just enough FSH to feed one, the biggest bird gets the worm, so one follicle grows to ovulation and the rest of them die. Well, I want all the birds to grow. Two things are true. Your brain is not going to send out enough to feed them all because it doesn't want to have 10 or 15 or 20 babies at one time. But also, you need to pre-treat very often in order to get the best result. So the way I like to think about this is to say, if I starve all the birds first and there is no big bird, so if I don't have any worms coming into the nest, then I'm gonna have all these baby birds and they're all gonna be very hungry. Now, if I dump a bucket of worms in the nest, there's gonna be enough food to get them all to grow at the same pace. And this is what we're trying to achieve with the IVF protocol. So stopping the brain from sending out any FSH is suppression, and suppression can be done with anything that stops FSH. Estrogen, progesterone, testosterone, birth control pills, ovulation blockers, and brain blockers. Different types of medications that either are hormones or hormone blockers work in different ways. And the selection process should differ based on your scenario. That is usually going to take 2 to 4 weeks. Then we're going to do the stimulation. And the stimulation is high doses of FSH. This is the bucket of worms going into the nest. So stimulation typically takes about 2 weeks. So after your doctor's chosen the protocol, they then should line it up on the calendar. So when you see your calendar, this will be the kind of the third part of IVF. You're going to see, okay, do I have suppression? Do I have stimulation? And then during the stimulation, this 2-week time period when the follicles are growing, you will come in for monitoring, ultrasound and blood visits every 2 to 3 days to watch these follicles as they are growing. And this is where we're making decisions based on your level, because the number of eggs that are mature will all make a certain amount of estrogen. When they get to the mature standpoint, the fourth step will be the trigger shot. The trigger shot is going to cause you to ovulate if we don't go get the eggs from an egg retrieval. But the reason why we need to do the trigger shot is that it finalizes the last stage of maturation of the eggs. Scientifically, there's a lot to be said, but the eggs are held in a specific stage of meiosis or cell division, and the trigger shot allows them to complete this stage so that they can be fertilized. I also like to think about the egg inside the follicle growing on the little edge. The trigger shot is going to allow it to come in to the follicle. The trigger shot can be twofold. It's either going to be HCG, because HCG binds to LH receptors. Remember, naturally, LH comes from the brain, and that's what's going to trigger ovulation. So HCG binds to those receptors. Or we can actually use Lupron, and Lupron's a medication. It's officially a brain blocker, but it's called a GnRH agonist. But it causes the pituitary gland to send out all of the FSH and LH that it has stored immediately after taking Lupron. Different reasons why we might use them, and some people use both. So the trigger is not a one size fits all. What we do know is that HCG triggers can sometimes have a higher risk of OHSS or ovarian hyperstimulation syndrome. So Lupron can have a lower risk of that. However, if you're on a Lupron-based protocol, you can't use a Lupron trigger. So you would have to use an HCG trigger. After the trigger, you're going to have the egg retrieval, which would typically be somewhere between 35 to 36 hours after. This is something that, like, my clinic does 35 and a half hours. Your clinic may have a specific amount. And some people need 30 minutes shorter, 30 minutes longer, and we don't know this till you go through the procedure. The egg retrieval is where we go vaginally with a needle attached to the ultrasound, and we enter into all of these follicles. These follicles will drain. Again, the test tubes will go to the lab, and they will identify the eggs. The procedure is really fast. You should get IV sedation so you don't feel any of it. Procedure will take typically about 15 minutes. You'll wake up, go home the same day. But from there, we start to get all the IVF math. So steps in an IVF process, now there's nothing for you to do, but all the magic is happening in the lab. And this is where IVF attrition really hits. So every egg is not going to be mature, fertilize, become an embryo, or be genetically normal. And this is what happens in the lab. The next thing to know is fertilization. So we'll get a sperm sample the same day as the egg retrieval, and then the sperm will be fertilized. There's 2 different ways. One is conventional. This is what we did originally. This is where eggs are in a petri dish. We squirt the sperm on top, cover it, put it in, and we see what fertilizes. The other option is what's called ICSI, ICSI, intracytoplasmic sperm injection, where a single sperm is picked up, the egg is cracked open, and the sperm is put inside. ICSI is indicated for any type of male factor. We use it a lot so that we do not have fertilization failure. especially in people who've not had a fertilization in the past. But ultimately, you should know which option you are having. And some clinics do Zymot for sperm selection. We do this. It's a microfluid chamber, but I like to think about it as the sperm obstacle course so that we can have better quality sperm. So ask your lab, how are we choosing sperm? What processes? Are we doing conventional or ICSI? You should know what is happening. Typically, about 75 to 80% of the mature eggs will fertilize, but then they have to grow to an implantation stage embryo called a blastocyst, and this is a day 5 or 6 embryo. So I want you to think, naturally, fertilization occurs in the fallopian tube, and that embryo grows and develops for 5 to 6 days until it gets into the uterine cavity. Once it gets in the uterus, this is where it can implant. One of the benefits of IVF is that this process takes place in the lab because your body is subject to inflammation and toxins and pH imbalance and temperature changes, and the lab is perfect. But even in that perfect scenario of the lab, we lose about 50% of the embryos from fertilization to blastocyst. And this is that IVF funnel or the attrition that is so hard. From this stage, once you get to blastocyst, embryos can be transferred. That's considered a fresh transfer. It's honestly not done as much anymore because fresh transfers are associated with lower live birth rates and higher pregnancy complications, probably because of some of the really high hormone levels. I'll say the exception here is somebody who's young and doesn't need genetic testing and has a very low egg count because their hormone levels won't be so high since every mature egg makes estrogen. But that would be the minority of my patients. The embryos can be frozen so that you could have a bleed and bleed off that high hormone exposed lining and then prepare for a frozen embryo transferred. Or they can be biopsied, and the biopsy sample can be sent off for PGT, pre-implantation genetic testing, and then the embryo can be frozen. Most patients are doing PGT now. There's a variety of different kinds, but PGT-A is the most common. This is pre-implantation genetic testing for aneuploidy or normal chromosome number. Now, aneuploidy can be influenced by how healthy you are, if you smoke cigarettes, your lifestyle, but it's also strongly influenced by age because the longer the eggs have been in your body, some of these chromosomes break down over time. So we know that if you're 35, 36, about 50% of those embryos that get to the blastocyst stage would then be genetically normal. And then that number drops as you get older. So it's really important to know from your doctor before you do IVF, what's my ovarian reserve? How many eggs might we expect? What protocol are we going to do? What fertilization are we going to do? Based on my numbers and my age, how many normal embryos do you expect? And yes, average by definition means some people do better and some do less good, but you should know what to expect if everything is perfectly average. And then one single genetically normal embryo, when we do a frozen embryo transfer, has about a 65% chance of success. That number sounds scary because it's not 100, but it's really great for reproductive literature. But the good news is that cumulative embryo transfers have a higher rate of success. So after 2 transfers, almost 85% of people will have a baby, and after 3, 95%. So if I have 3 genetically normal embryos, you have a 95% chance of having a child, and that's really reassuring news, even if it's not quite as high per transfer as we would love. I'm gonna have another video and dive into embryo transfer tips, protocols, and what to expect, but hopefully this helped you understand some of the steps for the IVF process. The last thing I'll say is I just covered IVF, in vitro fertilization, getting 1 month's group of eggs to grow, taking them out of the body, fertilizing them, and making embryos. Sometimes you have to do more than 1 round of it. So I'm gonna get this month's group of eggs and then next month's group of eggs. And those are multiple cycles of IVF. The FET, or the frozen embryo transfer, is the act of getting the body ready, warming up the embryo, and putting it inside. Thanks so much for watching this video. Ask your IVF questions below so that we can do a Q&A on this soon. And as always, I appreciate you guys. You can get more information on Instagram at Natalie Crawford MD. Listen or watch the As a Woman podcast and check out the Fertility Formula.